All right, first concerning the lab exam. So whenever you log into your Canvas, please press home. And when you press on home, scroll down to Unit 2. And when you see Unit 2, it's gonna have the urinary system lab exam. You're gonna be completing the lab exam as what you're used to with the lecture exam and the quizzes. They are gonna be, it's gonna be conducted through Canvas without proctoring. You have 35 multiple choice questions, which are diagram based, the same diagrams that we've discussed in class before our spring break. And we've got 2 essay questions. Each one is worth 10 points and the other one is going to be worth 5 points. This will give you a total of 15 points towards those 2 essay questions. All right, you have 70 minutes to complete this test. Please make sure when you complete this test, you have a reliable internet connection, a reliable computer device for this exam. Is you're gonna have only one attempt to get it completed. All right, so again, urinary system lab exam, you're gonna be opening the home page on Canvas. You scroll down to Unit 2. This is where you're gonna have the urinary system lab exam. You press on it and you're gonna be good to go. You're gonna be completing the exam. So let me get a student view for. This is how it's gonna look like from your side. When you press on it, it's gonna ask you to take the quiz. So press take the quiz. You have 8 diagrams. It's gonna be due on Monday. It's gonna be available. It's available from today until March 30th, which is a Monday. So you have 5 days to get it completed. 2 weekdays and the 3 weekdays and 2 weekend days. So we have Friday, actually three weekdays, which are today, Friday, and Monday, and you have Sunday and Saturday to get it complete. All right. They don't have to be the same ones. They don't have to be the same exact ones, but they are the same content. So they have the same content as what we've seen in class. The essay question is going to be what we've discussed in class. Yes, the blood pressure regulation by the kidney and the heart, atrial natriuretic peptide, and the angiotensin II. Anybody needs a review for the essay question? Two, three, four, five. All right, so let me go over it quickly. All right, so if you remember, we have two main topics here. We have the response to a reduction in the blood pressure. So if I did have a reduced blood pressure, how would I be responding? And if I have an increase in the blood pressure, how would I be responding? Remember, the part of your body that responds to an increase in the blood pressure, this was the heart, an increase in the blood pressure, and the kidney is the one that responds to the reduction in the blood pressure. So let's start with the reduction in the blood pressure. So if I have a reduced blood pressure, this causes what? This causes the reduction of the tissue perfusion. So you're gonna get less blood delivered to your kidney. And this will dramatically affect the kidney function. So if you remember, the part of the kidney that responds to this reduction was my juxtaglomerular apparatus. Juxtaglomerular apparatus, if you remember, consisted of three main sets of cells. We've got the macula densa, we've got the granular cells, we've got the juxtaglomerular mesangial cells. If you remember, the granular cells, those are modified smooth muscles. Of the afferent arteriole. And it's gonna be acting as a mechanoreceptor. What do I mean by mechanoreceptor? It's gonna be responsible to detect the degree of stretch applied to the wall of the arteriole. On the other hand, the macula densa, those are modified tool cells of the loop of Henle. And they act as chemoreceptors, detecting the concentration of the sodium in the filtrate. For the juxtaglomerular mesangial cells, those were acting as message carriers, as they have gap junctions in between. They allow the connection between the granular cells and the macula densa of the juxtaglomerular apparatus. And what allows them to do so is the presence of gap junctions in between. Granular cells, as they detect a reduction in the blood pressure, granular cells here are the ones that will be responding by releasing their granular content out in the bloodstream. And if you remember, the granules inside the granular cells contained renin. Once the renin gets released out in the bloodstream, it's going to be allowing you to convert a plasma protein called angiotensin tensinogen into angiotensin 1. This is under the effect of renin. Angiotensin 1 is not the active form of the enzyme that has an effect. Angiotensin 1 needs to be converted into angiotensin 2. And the enzymes that allows this to take place is called angiotensin converting enzyme. And the angiotensin converting enzyme is actually released from the endothelial lining of my capillaries. Angiotensin 2, this is the active form of the hormone. This is my active form of the hormone. This is the one that's going to have an action to increase your blood pressure. Remember, your initial problem is you have low blood pressure. So angiotensin 2 acts by 5 different means to increase your blood pressure. Remember, what are the different ways by which the angiotensin 2 increases the blood pressure? Remember first the structure of the nephron. Nephron was formed of a set of tubules connected to them. We've got capillaries. So the nephrons have Bowman's capsule, proximal convoluted tubules, loop of Henle, distal convoluted tubules, and the collecting ducts that will be collecting the filtrate from the different nephrons. The capillaries related to the nephrons, those were first the tuft of capillaries located within the Bowman's capsules. This is called my glomerulus. And we've got the blood into the glomerulus through the afferent arteriole, and it gets drained out from the glomerulus through the efferent arteriole. The continuation here of the efferent arteriole gives rise to a tuft of capillaries. This time they will be surrounding my proximal and distal convoluted tubules. We call the capillaries around those tubules. Those are my peritubular capillaries. How angiotensin 2 acts to increase your blood pressure. Also, you need to remember that the mean arterial pressure equals to the cardiac output, the amount of blood that you pump in 1 minute, times the total peripheral resistance, which is mainly determined by the diameter of your arterioles. The narrower the arteriole, the higher the resistance, and so the blood pressure. The larger the diameter of the arterioles, the lower the resistance and the lower the blood pressure. Remember, we did have another tuft of capillaries, which is straight vessels surrounding the loop of Henle. This is called my vasa recta. First action of angiotensin 2 will be to perform constriction of the arterioles. Here, I'm performing vasoconstriction. And as I perform vasoconstriction, this increases my total peripheral resistance, and as a result, I will have an increase in my mean arterial pressure. The second action here for angiotensin II will be by acting on the hypothalamus to do one of two things. All right, actually do the two things at the same time. It activates the hypothalamic thirst center. So once you activate the hypothalamic thirst center, this increases the water intake. And as you increase water intake, this results in an increase in your blood pressure, blood volume, and so the blood pressure. Another effect on the hypothalamus would be to stimulate the hypothalamic cells to release the anti-diuretic hormone through my posterior pituitary gland. And remember, the ADH will do what to your blood pressure and to your urinary secretion? Remember, ADH inserts channels within the tubular cells of the collecting ducts. Those are called aquaporine channels. Aquaporine channels will allow you to move the water from the collecting ducts to your blood vessels. This will do what to your blood volume? Increase your blood volume. Remember, if you're not releasing the water out in the urine, you are gaining this water as part of your blood. So this increases the blood volume, and as a result, you're going to have an increase in your blood pressure. A third action for angiotensin II will be to increase the sodium reabsorption. And remember, the sodium gets reabsorbed. 90% of it is going to be reabsorbed in the proximal convoluted tubules and the ascending limb of the loop of Henle. I have here a direct effect on the kidney tubules to try to increase the reabsorption a little. Also, I have a direct effect on the distal convoluted tubules and the proximal parts of the collecting ducts. This is a direct effect of angiotensin II, sodium, enhancing the sodium reabsorption. And when I reabsorb the sodium back, what's going to happen? The water follows, and as water follows the sodium, this will increase my blood volume, and so it will increase my blood pressure. Another way by which you're going to be increasing the sodium reabsorption, other than the direct effect of angiotensin II on your kidney tubules, it's going to be by stimulating the adrenal cortex to release aldosterone. Aldosterone is going to be a mineralocorticoid that is responsible to enhance the reabsorption in my distal convoluted tubules and from my collecting ducts. Another action for angiotensin II that we've seen was to contract the extraglomerular mesangial cells. And remember, where are those mesangial cells are located? They are kept in here. They are attached to the afferent arteriole. So when you contract them, this will allow you to pull the glomerulus away from the Bowman's capsule, reducing the exposed surface area available for the filtration. As I reduce the filtration, I'm not going to be losing as much water out in the kidney tubules as I used to, so this will increase my blood volume and so my blood pressure. Another actions that we've stated for angiotensin II was to constrict the efferent arteriole. And if you remember, how is this going to be allowing you to increase the blood pressure? When you constrict the efferent arteriole, this will reduce the hydrostatic pressure within your peritubular capillaries. So less fluid is circulating here. So I have less pressure within my peritubular capillaries. This allows better reabsorption of the water back from my kidney tubules. Remember, what allows the fluid to move is the difference in pressure. So if this was the difference between the two sides, this was my peritubular capillary, and this is my kidney tubule. If this is the difference between the two hydrostatic pressures, the rate of the reabsorption is going to be determined according to the difference between those two pressures. What if I did reduce this hydrostatic pressure within my peritubular capillaries to be like this? So I have less hydrostatic pressure within my peritubular capillaries, so the difference between the two pressures will be increased. And as I increase the difference between the two pressures, what's going to happen? This allows me to have more reabsorption. And if you increase the reabsorption of the water back to your blood, this will increase your blood volume, and so it will result in an increase in the blood pressure. Any questions so far on how your body responds to the reduction of the blood pressure, the mean arterial pressure? Any questions? All right, great. How my body now responds to an increase in my blood pressure. Remember, your heart is the one that hates to have high blood pressure. So how the heart will figure out that you have high blood pressure? When you get more blood back to your heart. When you get more blood back to your heart, this means that there is more blood than what I'm used to circulating out in my vessels. This, in other words, means that I have high blood pressure. So getting increased venous return, increased blood movement increased blood movement back to my heart, this will cause a stretch of my atria, stretch of my ventricles. This increase in the degree of stretch will allow the atria to release atrial natriuretic peptide. Atrial natriuretic peptide is the hormone that's going to be responsible to reduce your blood pressure back to normal. How the atrial natriuretic peptide is going to be conducting its effect? It has three target organs. First is going to act on the kidney, juxtaglomerular apparatus of the kidney. It's going to be inhibiting the granular cells from releasing renin. And if I don't have renin, what's going to happen? I won't be able to produce angiotensin II. Remember, you need renin to convert the angiotensinogen into angiotensin I, which is essential for you to form angiotensin II. If I don't have angiotensin II, remember the very first action of angiotensin II was to constrict the vessels, constrict the arterioles. So if I don't have angiotensin II, this results in vasodilation. You're gonna dilate the vessels, and as you dilate the vessels, remember, mean arterial pressure is gonna be determined by cardiac output and the resistance. So if I did dilate the vessels, this will reduce my total peripheral resistance, and so I have a reduction in my mean arterial pressure. Another target organ for my atrial natriuretic peptide will be my adrenal cortex. If you remember, adrenal cortex releases aldosterone. So here's the atrial natriuretic peptide is going to be inhibiting the adrenal cortex from releasing aldosterone. And if you're not releasing aldosterone, remember, you're going to be losing those 10% of the sodium out in the urine. And remember, what's going to be following the sodium normally is water. So I lose more sodium in the urine means I am losing more water out in the urine. And if I'm losing more water out in the urine, this is going to reduce my blood volume. And as a result, I will have a reduction in my blood pressure. The third target organ here for my atrial natriuretic peptide will be to act on the hypothalamus by inhibiting the release this time of the ADH, atrial ADA, antidiuretic hormone. When you inhibit the ADH release from the hypothalamus, this means that you won't be able to reabsorb back the water that got filtered out through your collecting ducts. So if you're not getting the water back to your blood because you don't have ADH, this means what in terms of blood volume? If I didn't reabsorb this water back, I will have a reduction in my blood volume. And as you reduce the reabsorption of the water back, reducing your blood volume, this is going to result in reduction in your blood pressure. So again, atrial natriuretic peptide that act by three different means to reduce the blood pressure. First one is by inhibiting the juxtaglomerular apparatus from releasing renin. Also, it inhibits the aldosterone release from the adrenal cortex and the ADH release from the hypothalamus. All this results in a reduction in my blood pressure back to normal. All right, this would be the other part of the question, which is how would you respond to any increase in the blood pressure? Any questions? All right, great. So let's continue our discussion of the immune system. If you remember, last time we have completed our discussion of the adaptive immunity. Today we are starting our discussion of the homeostatic imbalances that are related to the immune system. So starting here first with the immunodeficiencies. So immunodeficiencies might be congenital or they might be acquired. So we have, in some cases, congenital problems that are a result of an infection, for example, like HIV infection, as we're going to see. We have, in other cases, a child is born with congenital immunodeficiency. He has defective immune responses that will not allow him to fight the infections. So this might be caused to problem with the immune cells, like the phagocytes, or might be due to a problem in the complement that behaves in an abnormal way. The immunodeficiencies that we are discussing today is going to be the acquired immunodeficiency syndrome, or AIDS, and this is going to be resulting due to the interference with the activity of the helper T cells. So helper T cells, if you remember, were supposed to activate not sure if you can see here. They were responsible to activate and enhance the proliferation of both B and T lymphocytes. Also, they were responsible to activate the macrophages. So, keeping this in the back of my mind, I can understand why the immune system is going to be crippled. Because every single part of the immunity is going to be affected by having defective helper T lymphocytes. What is the cardinal signs here for the acquired immunodeficiency syndrome? Is going to be severe weight loss, night sweats, and swollen lymph nodes. And those are also the alarming signs of having a major problem. One of the major problems that we've seen last class that might be manifested by those alarming signs was leukemias. So leukemias and lymphomas might be manifested by those alarming signs. I have severe weight loss, night sweats, and swollen lymph nodes. And we're going to discuss later today and next class at a respiratory homeostatic imbalance that also can be manifested by those three alarming signs. The problem here is that anything can cause an infection. I have opportunistic infections that will be taking place, like in case of pneumocystitis pneumonia and Kaposi sarcoma. So what is an opportunistic infection? Opportunistic infection is simply a bacteria or a virus that takes advantage of the situation, which is reduced immune response. So I can't respond to the infection, and as a result, the bacteria that was living normally in my body without having any problem with it started to cause an infection. This is what we call an opportunistic infection. It takes advantage of the current situation. HIV is the virus that causes the acquired immunodeficiency syndrome. It's going to be transmitted through the body fluids. This includes blood, semen, and vaginal secretions. So HIV enters the body either through blood transfusions, which is very unlikely now because all blood that were taken or that were given to the patients needs to be checked for infectious diseases, including HIV. So this is not a problem anymore in most of the cases. Blood contaminated needles, and this explains why AIDS is common in drug addicts. So because drug addicts, if they don't have access to needles, they will be taking the drugs sharing the same needle. All right, so this can cause the transmission of the infection between the different members of this group. Sexual intercourse as well as oral sex, all this can cause the transmission of HIV. The problem here is with my helper T cells. This is going to cause a major depression of the adaptive immunity. Both B and T lymphocytes are going to be affected. Remember, in order for me to activate the CD8 cells, which will become my cytotoxic T lymphocytes, I need to recognize the specific non-self antigen, and in the same time, I need to recognize and bind to MHC class 1, if you remember, on the surface of my antigen-presenting cell. I need to recognize to MHC class 1. I need to recognize and bind to the viral antigen, for example, that I'm specific to target. But remember, in order for the CD8 cells to become activated and start to proliferate and give rise to the cytotoxic T cells, which is the active form of the CD8 cells, I need to receive a signal from the helper T cells, which was interleukin 2. So remember, the presence of interleukin 2 released from the helper T cells is essential for you to activate your CD8 cells that will become cytotoxic T cells. And remember, the cytotoxic T cells, this is the cells that would be responsible of finding any infection in your body cells and to destroy the infected cells along with the viral particles on the inside. Remember, this takes place by releasing the perforins and the granzymes, which are the digestive enzymes that will get injected inside the infected cell. So everything gets destroyed from inside. This includes the viral particles as well. So remember, this wouldn't have happened if I didn't get the signal from the activated helper T cells. So if HIV destroys the helper T cells, what's going to happen? You will not receive the signal. CD8 will not become activated into cytotoxic T cells. So cytotoxic T cells will not find the infected cells. And so any infection will start to get worse and worse without having any suppression from the cell-mediated immunity. Also remember, the helper T cells were responsible to enhance the proliferation of the B lymphocytes. So B lymphocytes are not going to be proliferating, are not going to be transformed into plasma cells, so they won't be producing immunoglobulins for you to allow the neutralization, the agglutination, the induction of the inflammatory process, the destruction of the bacterial cells by cell lysis and complement fixation and activation. All this won't take place if I don't have helper T cells. And again, helper T cells are the ones that will get affected in this disease, in the acquired immunodeficiency syndrome. Again, what is the name of the virus here that results in this? It's my human immunodeficiency virus, HIV. Another set of homeostatic imbalances that are related to the immune system are the autoimmune diseases. And autoimmune diseases gonna be a result of a defective immune system that loses the ability to distinguish between self antigens from non-self, from something coming from outside. So I will start to consider my own antigens as non-self antigens. So what's going to happen? I will be producing antibodies against my own antigens. I will be activating cytotoxic T cells to destroy my own cells. So I have production of immunoglobulins. By activating B lymphocytes, I have formation of activated cytotoxic T cells that will start to attack my own tissues. And this is not a common thing to happen, but when it happens, it's gonna be so hard to deal with. Examples on here is gonna be multiple sclerosis. If you remember, what was multiple sclerosis? If you remember the structure of a nerve cell did have cell body like this, with short tapering processes. Those are my dendrites. And long process, this was my axon that did have those telodendria. And remember, surrounding the axon, we've got the Schwann cells forming the myelin sheath in an interrupted way like this. In multiple sclerosis, I am activating the immune system to attack the Schwann cells and the myelin sheath. So what's going to happen as a result? This will form multiple sites of fibrosis. Whenever you get the inflammation and the healing process after you attack those Schwann cells, that's why we call this as multiple sclerosis. You have fibrous tissue in different sites throughout the length of the nerves. So what was the function of the myelin sheath, if you remember? First, it allows the insulation. So I'm preventing the electrical impulses from traveling from the axon to a nearby nerve cell. So I'm acting as an insulator. Also, it speeds up the transmission of the electrical impulse. So the electrical impulse, remember, it doesn't travel through the plasma membrane in the sites covered with myelin sheath. So the electrical impulse is going to be jumping from one node of Ranvier to the next node of Ranvier. So what's going to happen here, if you've got this sclerosis, this fibrosis throughout the length of the nerve, this will be slowing down the speed of the electrical transmission through the axons, and this will result in decline in the ability of the person to move, the ability of the person to breathe. So patients here, they keep, the condition here of the patients will keep worsening. If it gets so bad, it might result in respiratory depression because of the paralysis of the respiratory muscles. So the patient can't breathe anymore. Myasthenia gravis, if you remember. Myasthenia gravis, this was a disease, an autoimmune disease that was responsible to form immunoglobulins against the acetylcholine receptors at the neuromuscular junctions. If you remember, in order for your skeletal muscle to contract, it needs to receive a signal down from a motor neuron. Remember, when you get the signal down to the terminal lobes of the nerve cells, this allows the influx of calcium, and this calcium influx enhances the release of the neurotransmitter contained in those vesicles. Acetylcholine, once it gets released, is going to bind to its receptor on the sarcolemma, which is the cell membrane of the muscle cell, and will cause the opening of channels, creating an electrical impulse traveling this time in the muscle cell that will allow it to contract. So in this disease, I have autoimmune antibodies that are going to be competing with the acetylcholine binding to its receptor, blocking the acetylcholine from getting attached to its receptor on the muscle side. So what's going to happen as a result? I will have a reduction in my ability to contract my skeletal muscles. So important manifestations on here, I have eye drooping, eyelid droop, I have dropping of the eyelid, especially later during the day because of the accumulation of those autoimmune antibodies. So I'm not able to keep conducting the signals to my skeletal muscles to keep my eyes open. Also, I will have general weakness of the skeletal muscles. Graves' disease was an autoimmune disease that affects the thyroid gland. If you remember, the thyroid gland was formed of two types of cells. We've got the follicular cells, which are responsible to release the T3 and T4, a thyroxine hormone, triiodothyronine and thyroxine. And in the thyroid gland, we've got clusters of cells between those follicles, and we call them, those are the parafollicular cells. Those parafollicular cells, those were responsible to release calcitonin. The problem here is when you attack those follicular cells, when they get destroyed, they will start to release the T3 and T4. So I will start to have hyperthyroidism. But as the follicles get destroyed by the effect of the immune system, I will start to notice a major reduction in the thyroid hormone release. So I start with having hyperthyroidism, then I have hypothyroidism later. Type 1 diabetes. In type 1 diabetes, my problem is that I am attacking the Langerhans cells. And remember, Langerhans cells, those are clusters of cells located in the pancreas that are responsible to release insulin. So attacking those cells, destroying them, this results in a major reduction in my ability to release insulin. So this results in an increase in my blood glucose levels and won't allow me to use the glucose I am getting through the food. Systemic lupus erythematosus. This is a systemic disease. What I mean by systemic, it's going to be affecting multiple organ systems. It's going to be affecting the kidneys, affecting the skin. One of the most common manifestations of systemic lupus erythematosus is that this butterfly-shaped rash on the face. So if I'm drawing a face on here, it's more common in females. All right, so butterfly-shaped rash is gonna be occupying here. Or another name for it is gonna be Muller rash. So lupus means wolf. It looks like a wolf. See on here, the distribution of the rash on the face will make it like a wolf. All right, that's what lupus means. Lupus means wolf. Erythematosus, it's reddish, a red wolf. And it's not only affecting the skin, it's affecting multiple other organ systems. That's why we call it systemic. Systemic lupus erythematosus. Glomerulonephritis, from the name, I am attacking the glomeruli, causing the destruction of the glomerular cells, along with the basement membrane in some cases. Rheumatoid arthritis, this is also a systemic disease, and one of its major manifestations would be that it causes the inflammation of the joints. So I have induced inflammation within the synovial joints, which will make the joints more stiff, harder to move because of the inflammation. Usually it's going to be stiff pain joint early in the morning. So I have stiff joints early in the morning. Why early in the morning? Because I'm not moving, so the immunoglobulins will get a chance to start to accumulate and induce inflammation. I'm not moving, so there will be less fluid circulating, and this is a good chance for the antibodies to cause more inflammation of the joint. All right, so early morning joint pain and stiffness is going to be a major sign, one of the major manifestations here for rheumatoid arthritis. Again, all those are autoimmune diseases. Either you did activate B lymphocytes against the self-antigen, so you're going to be producing autoimmune antibodies that will be attacking your own antigens, or you did mistakenly recognize a self-antigen and you did form cytotoxic T cells that are going to be attacking your own normal cells without them having an infection or without being cancerous cells. Our last homeostatic imbalance today, I believe, it's going to be the hypersensitivities. And a hypersensitivity is an immune response, an exaggerated immune response to something that is harmless. So like pollens, for example, or dust particles, rather than neglecting those non-destructive, non-harmful particles, I will consider them as a major threat and I will start to respond accordingly. So I have exaggerated immune response against something which is harmless. Type 1 hypersensitivity or allergies, those will start in seconds after the contact with the allergen. So what is the problem in here? The problem, if you get exposed to something that you have hypersensitivity for, and this caused a systemic release of histamine. What happens if I have major release of histamine? If you remember, what's inflammation in one word? Can you remind me, just to check if somebody is still here? Vasodilation. Vasodilation. All right, so again, one word that describes inflammation is vasodilation. It dilates the vessels. And if I have vasodilation, what's going to happen? If I am dilating old arterioles, if you are dilating a large number of arterioles all in the same time, this is going to cause a major reduction in your total peripheral resistance. And if you are reducing the total peripheral resistance, what's going to happen to your arterial pressure? Remember, if I have reduction in my total peripheral resistance, this will cause a major drop in my blood pressure. And if I reduce the blood pressure, this results in a reduction in my ability to deliver the blood to my tissues. I have a reduction in my tissue perfusion. And if I have a reduction in the tissue perfusion, this is what we call a shock. It's a type of vascular shock, if you remember back from the vascular system. We call this type of vascular shock, it's my anaphylactic shock. It's not only about the reduction here in the blood pressure, it's gonna also be causing constriction of the bronchioles. This is another inflammatory reaction. Other inflammatory reaction that results in from hypersensitivity is major bronchoconstriction. So the person has major drop in the tissue perfusion and he can't breathe because he has constriction of the bronchi. So if those are my bronchi on here, if you constrict the bronchi, what's going to happen? Bronchoconstriction. This will reduce your ability to move the air in to reach your air sacs for you to have the gas exchange. So I need to do what? I need to give bronchodilators. I need to give something that will cause an intense constriction of the arterioles for me to maintain the normal tissue perfusion. All right. Questions? Any questions for me? All right, great. So let's have a break for 10. We come back, discuss more about the respiratory system. We're gonna start after break our discussion of the respiratory system. All right, welcome back. All right, so today we are starting our discussion of the respiratory system. In this chapter, we are discussing the anatomy of the respiratory system, the mechanics of breathing, and we're going to discuss the principles of gas exchange, how the gas is going to be transported from one side to another. We're going to be discussing the factors that will affect the breathing rate and its depth. Also, we're going to learn about the respiratory adjustments that will be taking place with exercise and change in altitude. We're going to discuss the homeostatic imbalances that will be impacting the respiratory system towards the end of the chapter. So first, starting with the functional anatomy of the respiratory system. First, we've got the nose, and inside we've got the nasal cavity. This takes us to part of the pharynx that is located just behind the nose, behind the nasal cavity. This is called my nasopharynx. And then the air moves down to the part of the pharynx located posterior to the oral cavity. This is going to be my oropharynx. And then down to the part of the pharynx located posterior to my voice box or the larynx. This is called laryngopharynx. And then the air then travels to the larynx, the voice box on here. Then down to the trachea. And then the trachea branches into the bronchi. And keeps branching into much smaller branches. Those are my bronchioles that will end up at the cluster of air sacs formed of alveoli. Together, the bronchioles and the air sacs will form my lungs. This is going to be the main part of the respiratory system. So this is the functional part. So again, nose, nasal cavity, then the part of the pharynx located posterior to the nasal cavities is going to be my nasopharynx. Then the part of the pharynx located posterior to the oral cavities, this is my oropharynx. And then the part of the pharynx located posterior to my larynx, this is my laryngopharynx. Air will then travel down into my larynx, then to the trachea, to the bronchi, bronchioles, and then to the air sacs where I have most of the gas exchange. All right. So looking on here, this is going to be the nose, nasal cavity, nasopharynx, oropharynx, laryngopharynx, larynx, trachea, bronchi, and then smaller branches on the inside. Those are the bronchioles, and the air sacs all together will form my lungs. Looking here at the anatomical structure of the upper respiratory system. So this is one of the important diagrams. This is going to be a 5 stars diagram for the upcoming lab exam. This is a 5 stars diagram. So what we're looking at in here, first we are looking at the nose. The nose has a bony part and a cartilage part. Remember the type of cartilage that forms the nose? This was the hyaline cartilage. The nasal nostril, this is the opening on here. And I would see a depression in the nasal mucosa at the entrance of the nose. This is going to be my nasal vestibule. So we've got here, this is going to be my nostril. And this is going to be my nasal vestibule. Inside the nasal cavity, what we can see on here, we can see 3 bony elevations. 3 bony elevations covered with mucous membranes. Those are going to be my nasal concha. So we've got the superior nasal concha, middle, and inferior nasal concha. In between the nasal concha, those are the tracts where the air is going to be traveling. Those are my nasal meatuses. So again, we started first by the nasal nostril, which is the opening here. At the entrance, we've got this depression in the mucosa. This is my nasal vestibule. We've got those eminences, bony eminences on the inside of the nasal cavity, which are covered with mucous membranes. Those are my nasal concha, superior, middle, and inferior. In between the nasal concha, those are my nasal meatuses, superior, middle, and inferior nasal meatuses. This takes us to the part of the pharynx located behind the nasal cavity. This is going to be my nasopharynx. All this is my nasopharynx. In the nasopharynx, I can see here a tonsil. This is called the pharyngeal tonsil. And you see this depression is where I have the opening of a tube that connects the nasopharynx to my middle ear. This is called my pharyngeotympanic tube or the Eustachian tube. If you remember, back when we studied the structure of the ear, got an external ear formed of ear pinna, external auditory meatus that ends up at the tympanic membrane, And remember, in order for the tympanic membrane to move freely responding to the sound waves, I did need to have an equal pressure on both sides of the tympanic membrane. This takes us to the middle ear, where I've got 3 tiny bones. Those are the medius, incus, and stapes that will be conducting the vibrations of the tympanic membrane towards my internal ear, where I've got the receptor responsible for hearing. This was the organ of corti inside the cochlea. Remember, in order for me to equalize the pressure between the middle ear and the external auditory meatus for the tympanic membrane to move freely, I needed to connect the middle ear to the external atmospheric pressure. So how would I do this? By the pharyngeotympanic tube. This tube on here is what's going to be connecting my middle ear to my nasopharynx, and here this is going to be the opening of the pharyngeotympanic tube. Just below the nasal cavity, we can see the oral cavity. The hard palate is going to be formed of 2 bones. Remember, we've got the palatine bone and we've got the plates from the maxillary bone. Posterior to the bone, to the bony part of the palate, the hard palate, we've got the soft palate, which is mainly formed of muscles. So here, this is going to be my soft palate. If you can see on here, we've got, this is my hard palate, and this is going to be my soft palate. The lower part, pending down in the middle, is going to be called my uvula. All right, this is my uvula, where it's a continuation of the soft palate down, pending down in the middle of the entrance of the oropharynx. We call all this part of the pharynx located behind the oral cavities. This is my oropharynx. Oropharynx. This is where I can see 2 tonsils on here. I can see the palatine tonsil and the tonsil related to the tongue. This is going to be my lingual tonsil. For you to imagine how the palatine tonsils look like, see on here, anterior view of the oral cavity. If this is a tongue like this, protruded to the outside, I've got 2 arches, the palatopharyngeal and the pharyngeal arch, like this. On both sides, between the 2 arches, we've got the palatine tonsils on here. So when you go to the doctor, when you have flu or an infection, he will ask you, especially in children, to protrude your tongue, and with a tongue depressor here, it's going to be depressing your tongue to check if you've got inflammation of those tonsils or not. All right, those are my Palatine tonsils. All right, this is the ones that you can see on here in the oropharynx. If we kept moving down, you can see the part of the pharynx located behind the larynx. This is my laryngopharynx. And anterior to it, you've got the larynx, which is formed of multiple cartilages. We've got the one above the larynx. This is my epiglottis. We got the epiglottis. Epi means above, and glottis, glotto is the vocal cords. Another cartilage that shares in the formation of my larynx is going to be a thyroid cartilage. Thyroid cartilage. This is where you're going to keep the vocal cords or the vestibular folds on here inside your larynx. So looking again at the most important structures that we need to identify in the upper respiratory system. So we've got first my nasal nostril, nasal vestibule, my superior, middle, and inferior nasal concha. In between them, we've got the nasal metastasis, superior, middle, and inferior. Located posterior to the nasal cavity, we've got the nasopharynx. This is where I can see a tonsil on here. This is my pharyngeal tonsil and the opening of the eustachian tube or the pharyngeotympanic tube, which is responsible to equalize the pressure on both sides of the tympanic membrane. Underneath it, we've got the oral cavity. This is my hard palate. This is the tongue. This is the soft palate. The pending part of the soft palate is what we call the uvula. On both sides of the oropharynx, we've got the palatine tonsils. And related to the tongue, we've got the lingual tonsil. Moving down, we've got the part of the larynx located posterior, the part of the pharynx located posterior to the larynx. This is my laryngopharynx. Anterior to it, we've got the larynx. You're going to see multiple cartilages that will share in the formation here, including the epiglottis, thyroid cartilage, cricoid cartilage. And on the inside, we've got the vestibular folds. This is where you're going to have your vocal cords. Down below the laryngopharynx, we're going to have the esophagus, which is just the continuation of the laryngopharynx that will be responsible to conduct the food and liquids towards your stomach. Any questions? Any questions? The uvula is going to be responsible to contract, moving upwards to close the nasopharynx while you are swallowing. So for example, on here, if I'm drawing this, this is my nasal cavity, my nose, my nasal cavity on here. This is my hard palate. This is a soft palate. And this is going to be the uvula. This is the tongue like this. So if I'm swallowing, I've got food in here, or let's say liquid. you want to allow those liquids down into your esophagus and stomach, and you don't want to have those liquids down into your airways. So in order for you to prevent the passage of the liquids down into the larynx, what you're going to do, you're going to be moving your larynx upwards, and you kink the epiglottis. So this is my epiglottis on here. This is my epiglottis. It kinks down, closing your lower respiratory tract. So the liquid won't be able to move down towards your lungs. At the same time, you don't want to have the water, this water coming out of your nose like this. So what you're going to do, you're going to be contracting the uvula to close the upper respiratory tract. So in order for you to move anything, what you're going to do, you're going to be contracting. So the pharynx is supposed to contract on here for it to be able to move the food or liquids from the oropharynx down to the laryngopharynx, down to the esophagus, down to the stomach. So if I contracted the oropharynx, I'm creating a high pressure because I'm reducing the volume. Remember, relationship between the volume and the pressure. When you reduce the volume, pressure goes up. So having high pressure in here within the oropharynx, this means that it tries to escape from this high pressure. So it tries to escape to a site with lower pressure. So I will either go down or I will go up. I have two options. Why, when you swallow, when you drink, you're not getting the food up into your nasal cavity, the liquids up into your nasal cavity, because simply the uvula here is going to be blocking the passage of the food and liquids up into your nasal cavity. All right, does this make sense, Tyler? All right, so an example here, if you are laughing and drinking in the same time. So if you're laughing and drinking and you're trying to breathe, so you're trying to depress the uvula and you have water in your oropharynx. So what's going to happen? The water going to be moving up into the nasal cavity and will move out of your nose. All right, this is the function here of the uvula. All right, any question? Any other question? Can I cross out the ones that you don't need for the test? You need all of them. For Hanan, you need to know all of them. All right, so moving on to how do I produce voice? So what is speech? First, speech is an intermittent release of expired air. So I am breathing out air from my lungs, and as the air travels up into my larynx, this is gonna cause the vibration of the vocal cords. So I need the larynx on here. If I'm looking at the larynx, like this, those are my vocal cords, my true vocal cords. Those are the ones that will vibrate to emit the sound. Like if you have a guitar, this guitar has chords like this. And once they vibrate, they emit a sound. Do they all produce the same exact sound? What do you think? No, they are not producing the same exact sound. So same concept on here when we're dealing with the vocal cords. Vocal cords, if you are willing to produce a sound, they shouldn't be either closed like this, or they are widely open like this. They need to be in between. So they are not closed. Why? Because if they are closed, there will be no air traveling. And they are not widely open because they will not be vibrating. You need something in between. You need something like this. It's a semi-closed position. Having the air traveling out, so this is my trachea on here. I'm carrying the air out of my lungs up, and this air, as it travels out of the larynx, while it's semi-closed, this is gonna cause the vibration of my vocal cords. Vibration of the vocal cords is gonna be emitting a sound. This sound gets modified by the effect of the chambers of the pharynx, the oral cavity, the nasal cavity, the sinuses, and this enhances the quality of the sound. For you to be able to modify this sound that has been amplified, traveling through your oral cavity, through the nasal cavity, and the sinuses, nasal sinuses, you're gonna be shaping this sound by contracting large groups of muscles. This includes the pharynx, your tongue, soft palate, and lips. So try, for example, to say O without pursing your lips. Can you say O when you are smiling? Can you smile and say O in the same time? Smile and say O. Anybody did it here? Right? It won't be an O, right? So there will be no modification of the sound. All right? What determines the pitch of a sound and what determines the loudness of a sound? What is the pitch of a sound first? The pitch of a sound is like when you are vibrating the thick chord on the guitar and you're vibrating thin chord on a guitar. So which one gonna be vibrating faster than the other? The thick chord or the thin chord? Faster is going to be this thin chord, right? Thank you. Right, so I am producing much more sound waves as I have a faster vibration. This is a high pitch sound. Compared to the thicker chord, it's going to be vibrating much slower compared to the thin one. So this is going to create a low pitch sound. So again, what determines the pitch of a sound that is emitted is going to be how fast the vibration is taking place. If I have a slow vibration, this is going to be a low pitch sound. Or high pitch sound. All right. So high pitch sound means I have faster vibrations. So how can I do this with my vocal cords? What determines the thickness of the vocal cords is going to be the degree of stretch. So let's say this is the vocal cord from a side view. This is a relaxed vocal cord. So it's much. So when I stretch this vocal cord, what's going to happen to its thickness? I stretch the vocal cord. So what happens to the thickness of the vocal cord? This is a relaxed. This is stretched. So when you stretch, it's going to be thinning out, exactly. Becomes thinner. So in order for me to produce a high-pitched sound, what will I need to do? I need to do stretch of the vocal cords. And in order for me to produce a deeper sound, a low-pitched sound, is going to be, I need to relax the vocal cords. Does this make sense? So again, what determines the pitch of a sound is going to be how fast you've got the vibration. Slow vibration, low pitch sound. Fast vibration, high pitch sound. What's going to be determining on here whether the cord is relaxed or it's stretched. The vocal cords are made of connective tissue. So we have got true vocal cords. Those are the ones that are going to be vibrating. The white on here, those are the true vocal cords. Those are the ones responsible for the vibration and emitting the sound. And we've got false vocal cords on here. Those are muscles. Those are not vibrating. Those are not emitting any sound. So the vocal cords that will be vibrating, emitting the sound, those are formed of connective tissue. And that's why some singers, because they keep stretching their vocal cords, this can cause an inflammation that heals by a formation of a papule, right? Singer's papule, which is due to the inflammation of the stretched vocal cords. As I keep stretching my vocal cords, this might result in something called the teacher's or singer's nodule. Singer's or teacher's nodule is simply a nodule that gets formed due to the irritation of the vocal cords. So again, vocal cords, areole, are formed of connective tissue. All right, I'm not sure if this is gonna work. Let me check on here if this video gonna work or not. So we're looking here at an endoscopy of the upper respiratory system. So passes through the nasal cavity. We've got the nasal septum here on the right, so we are in the left side of the nasal cavity. And we've got the inferior turbinate, inferior nasal concha. Keep moving backward. Now we're looking at the nasopharynx, the part of the pharynx located posterior to the nasal cavity. And on the side, if you remember, we've got the opening of a tube that connects the nasopharynx to my middle ear. And this is going to be the pharyngeotympanic tube or the eustachian tube opening. And this is going to be underneath me is the soft palate. We will ask the patient to swallow in order to allow the endoscope to pass the inside. What I see on here is this going to be my larynx. And remember the cartilage located just above the larynx that's going to be kinking to prevent the passage of the food and fluids down into your lower airways. This is going to be the epiglottis. And down here, this is going to be my voice box, my larynx. This is my pharyngeal wall of the oropharynx. I kept moving. So this is going to be the laryngopharynx, the part of the pharynx located behind the larynx. Notice on here how the chord's going to be moving, how the chord's going to be vibrating. So I'm asking the patient here, I'm asking her to vibrate or to speak. So this is a low pitch sound. So you see on here, the vocal cords are relaxed. This is how fast the vibration is taking place. Notice how fast the vibration is going to be taking place on here. So slow, 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 stretched, fast, 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 fast. Again, one more time. Here, looking at low pitch sound first. We have slow vibration, slow vibration, slow vibration, slow, 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 then a stretch, fast. All right. So for Michelle, what determines if someone's voice is high or deep in general? When they speak, if we will have same vocal cords. So it's gonna be determined according to how thick those cords will be. So for example, under the effect of the sex hormones, females will have more elastic and more thin vocal cords, so they have a higher pitch voice compared to males. Males will have, under the effect of the androgens, under the effect of the male sex hormones, they tend to get thicker vocal cords, and this results in having low pitch of their voice. Does this make sense? And also, like Hanan said here, like as you get older, the cords gonna be slightly thicker, so you're gonna have deeper voice as you get older. especially seen in females. Does this answer your question? All right, so this is when I'm looking at the pitch of the sound. So again, what determines the pitch of the sound is going to be the length and the tension of my vocal cords, how thick or thin the vocal cords are. This is what's going to be determining the pitch of the sound. And what determines the loudness of the sound is totally different. Loudness is not going to be determined according to how fast the sound waves are produced, but the loudness of a sound is going to be determined according to the amplitude of the sound wave. How big is the sound wave? The larger the sound waves that you are producing, the louder the sound, and the smaller the sound wave is going to be, the softer the sound. All right, so looking on here at the loudness, so what's going to be determining the amplitude of a sound wave? It's like when you have a sub, for example, in your TV or whatever. All right, so if you put your hand or any speaker, so if you are reducing the volume, and you put your hand in front of this speaker or this subwoofer, do you feel the same amount of air moving as you did increase the volume of the speaker? What do you think? So if you are in your car, you reduce the volume of the sound and you put your hand on the speaker, you're going to have more or less air moving. And if you are increasing the volume of the sound, you got more air moving. So the loudness is going to be determined according to what? According to the amount of air that you're moving. So the more air I am moving out of my lungs, the louder the sound I will be emitting. The less air I will be moving out of my lungs, this is going to be this is going to be producing a softer sound. So again, the more air going to be producing more or louder sound, less air is going to be producing a softer sound. So it's going to be the loudness is going to be determined by the force of air. And what I mean by the force of air, this is the amount of air in time. So you might be moving 2 liters of air out of your lungs, but over 30 seconds. And you might be moving the same amount of air, 2 liters, but in 2 seconds. So which one is going to have a greater force? The one with less time. So the amount of air is not only an amount, it's an amount in a time period, right? So more air per time is going to be determining the force of air that you're breathing out, and thus it's uh, the uh, the loudness of a sound. Make sense? Make sense? All right. So moving on to the anatomical structure of the larynx. If we're looking on here, this is going to be the base of the tongue. Located posterior to it, we've got the cartilage that's going to be preventing the passage of the food and fluids down into my lower airways. This is going to be my epiglottis. Then if you see on here, inside the glottis, the voice box, you can see you've got muscles. And attached to those muscles, you've got the actual connective tissues that's going to be vibrating. So we call this connective tissues that's going to be vibrating. This is the true vocal cords. True vocal cord. Or another terms that we use for it is going to be my vocal fold. Compared to the muscle part, the muscles on here is going to be stretching or relaxing the vocal cords. Those are my vestibular folds. Vestibular folds. Another name that we use for this here are my folds vocal cords. Those are not the true vocal cords emitting the sound. They are just muscles that will be responsible to determine the degree of stretch of the sound. The whole thing on here where I've got the true vocal cords is my glottis. Posteriorly, you're going to have two cartilages that will share in the formation of the voice box. The larynx is going to be the cuneiform, those going to be the cuneiform cartilage and the corniculate cartilage. Those going to be moving along with the, according to the degree of contraction or relaxation of the vestibular folds on here, the false vocal cords. If you open the glottis, you can see here the inside of the trachea with the tracheal rings on here. Remember, the tracheal rings are going to be cartilage rings that will keep the trachea open, so it doesn't collapse like the esophagus. The esophagus is only muscles, so it's collapsible. But the trachea, you can't collapse the trachea, right? Because of the presence of those hiding cartilage rings in its structure. This is another important diagram for our upcoming lab exam. I would rate this diagram as a 4 stars diagram. All right, so let us start on Tuesday our discussion of the lower respiratory system. So let's have the activity for today. So please name the different parts here of the respiratory system that I will be drawing on here. This is going to be your activity for today. All right, so this is going to be the diagram on here that you're going to be completing as the activity for today's meeting. So please name the different parts on here marked on the diagram. And this completes our discussion for today. Anybody has questions for me? Mateen, which diagram do you mean? Which diagram do you mean? Anybody still here? The 4 stars diagram, this one on here, this is a diagram showing the vocal cords and their relationship.